Hello, cruel world. My name is Dr Shaham Das. I'm a consultant forensic psychiatrist and NHS doctor. I assess mentally disordered offenders for a living so that you don't have to. This episode is a reaction video to a clip that I was sent by one of my viewers. It is Professor Huberman, and he's talking about the science and treatment of bipolar disorder. I'll put the link to the original video in the description. So I just want to be crystal clear, this is in no way a diss video. In the past, I have commented and criticised other non-legit YouTubers for talking about issues they don't know about, but this is completely different. This is a very informative, excellently made video. I agree with pretty much everything that he said. In fact, I go further than that. I've even been reminded about or learnt a couple of new things. What I'm bringing to this and my reaction is more about the clinical aspect. So I think he's talking about everything theoretically. I don't think he's a clinical psychiatrist himself. I've assessed and treated dozens, if not hundreds, of people with bipolar affective disorders, sometimes in the context of criminal proceedings. So I'm trying to add to rather than take away. Just going to give you my little insights and my comments as somebody who treats this. Okay, let's get straight into it.
There are basically two kinds of bipolar disorder, referred to as bipolar 1 and bipolar 2. So let's just talk about bipolar 1 first. Bipolar 1 is characterized by a fairly extended period of mania. What is mania? Mania is a period of very elevated mood, energy, distractibility, impulsivity, and some other symptomology that we'll talk about going forward. But this manic episode is extreme. This is a condition in which the energy lift, the mood lift, and the sort of impulsivity and actions and words of the person suffering from manic bipolar disorder are very noticeable and very extreme. Now, a key thing, however, is that it's not always noticeable to the person suffering from it that they are in this mode. Sometimes they recognize that, sometimes they don't, but it's always highly recognizable to other people that the person suffering from manic bipolar disorder is not like other people.
So what he's talking about is a lack of insight, and I completely agree. So when people are elevated in their mood, when they're suffering from mania, as Huberman says, it's like this intense but really good feeling. It's not always really good. Sometimes it can be linked to irritation and aggression, but I'll come to that. But because they feel high and they feel happy, they don't want this feeling to stop. They often don't want treatment or think they need it. If you think that you're feeling yourself, you've got this confidence, you've got this energy, why would you want that to stop? So he's picked on a key point. It's often other people, unlike depression, for example, in a phase of mania, it's often other people, friends, families, neighbors, doctors, police even, who realize there's something wrong and bring these people in for treatment. They themselves lack insight.
So let's talk about bipolar 1 in a little bit more depth. One of the key clinical criteria or diagnostic criteria for bipolar 1 is that a person suffer from these manic episodes or display these manic episodes for 7 days or more. That turns out to be very key. The stability of that manic episode for 7 days or more turns out to be very important. And for those 7 days, the person is in an elevated mood, expansive thought all day, every day for those 7 days.
With respect to Huberman, I'm not sure that it always fits into such a clear pattern. So what I'm saying is, 7 days is kind of the definition. From my experience, I've definitely assessed some people where it can fluctuate even within that time period. So even within your phase of mania, you can have mini kind of crashes and you can come back up fairly quickly. It's unusual, but it does happen. And I don't think, put it this way, somebody who fits that exact pattern but doesn't have it continuously still, in my view, would be classified as suffering from mania, would still have this diagnosis of bipolar. So we need to be careful about being too technical with the definitions.
Now, there are a lot of reasons why somebody could be in a manic mode. It doesn't necessarily mean that somebody has bipolar disorder. In fact, someone could be in a manic mode for 7 days or more and still not be diagnosed with bipolar disorder. Why? Well, there are other things that can create manic episodes, things like traumatic brain injury, things like seizure, things like various prescription drugs or illicit drugs, things like amphetamine and cocaine. That is not the same as bipolar disorder, even though from a symptomology perspective, they might look even identical?
So yeah, I agree with what Professor Huberman's saying. So the presentation is very similar. Let's take like a huge cocaine binge, or even say drug-induced psychosis caused by crack, let's say. The symptomatology is very similar to mania, but it's not, I'm being a bit semantic here, but I would argue that that's not a manic episode. It's like a pseudo-manic episode, or it's a state of behavior that presents like a manic episode, but he's calling it like similar to mania, but you wouldn't get the diagnosis. I would respectfully disagree with that. So to give you a specific example, if somebody's on a crack binge, they might be, struggling to sleep. They might be full of energy, obviously, because they're intoxicated, but they wouldn't be hungry at all. They'd barely eat in that period of time. Whereas somebody in a manic episode would be really hungry because they're burning all this energy. They'll eat almost constantly despite putting on weight. So I suppose the point I'm trying to make is it's not quite the same, even though it presents the same. And the other thing is that even though what he's saying is absolutely right, and a good psychiatrist should always investigate other potential reasons for somebody being tipped into mania. So something that I don't think he mentioned was hyperthyroidism. So if your thyroid glands are overactive, thyroid sits here, it can cause a manic episode. And even though you should rule these things out by doing blood tests, etc., I have to say from my clinical experience, it's extremely rare, extremely rare. I can think of maybe one patient off the top of my head that I've seen out of hundreds who actually had a brain tumor. And again, you have to rule these things out, because otherwise you might be treating the wrong thing. And it's something that we learn about when we're training as psychiatrists, but in practice, from my experience, extremely rare. It's usually functional, which means that it's usually caused by bipolar affective disorder.
So let's think about these symptoms and the diagnostic criteria that a psychiatrist would use in order to ask whether or not someone is manic because they have manic bipolar disorder, or whether or not that person is manic for some other reason, such as traumatic brain injury, illicit drugs, etc. So typically a person will be brought into a clinic, or a person would bring themselves to a clinic or meet with a psychiatrist. It seems more likely that they would be directed toward a psychiatrist, because oftentimes people who are in a manic episode just simply won't have the perspective or the foresight to bring themselves into the clinic.
Yeah, this is absolutely correct. It kind of reflects what I was saying before. I don't think I can think of, actually no, I was about to say, I don't think I can think of a case where somebody is self-presented with being suffering from a period of mania. I've seen it when I've had to section people and they're brought in by the police because, for example, they're running around naked or being aggressive, or doing something completely uncontainable, like shouting in the middle of the street. However, there are exceptions, and the exception from my experience is people who have had this disorder for a very long period of time and has been through lots and lots and lots of different relapses. Over time, they gain insight. So even though they feel great inside and they don't necessarily want this feeling to stop, they've learned that it can be quite damaging. So those are the small proportion of people that will self-present. But yeah, the other context that I see people in is when they've been arrested by the police, because I work with offenders.
And the psychiatrist is going to start to evaluate for a couple of different things. But first of all, what they're going to try and figure out is whether or not the person has at least 3 of the following symptoms. The first symptom is distractibility. Is the person distractible? Are they going from one thing to the next? People who are in a manic episode will be talking about a pen, and then they'll be talking about, something they saw the other day, and then something they want to purchase, and then a place they're going to travel to, et cetera. But they are also very prone to any stimulus within the room, meaning, a bell could go off, or there could be a sound out in the hallway, and they'll orient to that. And then they'll orient to the clinician, and then they'll orient to something in their pocket. So they're all over the place. You could think of this a little bit like ADHD, or attention deficit disorder, but it's very extreme. So highly distractible.
I think the professor has done an excellent job of describing what it's like to sit in a room with somebody who's manic. So as he says, they're just their focus constantly shifts, and you can't really get them to explain anything, because they're jumping from topic to topic to topic, which we call a flight of ideas. And anything that they think of that reminds them of something means they shoot off in another direction, either in the way they're talking or physically. They're very active. They can't sit still. They're sort of jumping up and down, constantly being distracted by things. He did say it's a bit like ADHD. I mean, I suppose in ADHD you get distractibility, but this is different because in ADHD it's because they can't, how do I put this? It's because they lose their focus, but they want to stay focused on one thing, but they don't have the ability. Whereas in mania, their level of focus is so low that they literally cannot and do not want to, because they're full of this energy. I suppose that's the difference. They've got this full of this energy and this good mood that you don't have necessarily in ADHD. So it's more because they want to talk about other things, whereas in ADHD, they want to stay focused, but they struggle to, if that makes sense.
Highly impulsive. Impulsivity relates to actions. So the person might be fidgeting with something and then they might try and leave the room, or the person might, if they were out in the real world, somebody might notice that the person is going and purchasing, multiples of something that would be unusual for someone to purchase. So for instance, I happen to know someone whose ex-spouse had bipolar disorder, and their ex-spouse went out and bought 10 plus air fryers, right? I mean, I think unless you're a restaurant that's using a lot of air fryers, the idea that you would need more than 1 or 2 air fryers might just seem a little bit out of the norm.
Firstly, surely more than 1 air fryer is too much. Why do you need 2 air fryers, Professor Huberman? How many people are you cooking for, and how big are your chicken nuggets? No, but joking aside, yeah, absolutely. So I have watched this video before, but I can't remember whether he gets to it or not. Impulsivity, absolutely. Buying things that you don't need. I remember assessing a man recently who, during a manic episode, completely converted his downstairs garage into a gym, spent not hundreds, but spent thousands of pounds buying all this gym equipment, and then I don't think he used it once. But in the moment, in his mind, he thought that was exactly the right decision. So absolutely, financial concerns, betting loads of money on stupid bets because you think you're convinced you're going to win. Sexually impulsive behavior. So a lot of people are quite promiscuous and then regret it afterwards when they're more lucid. Anything sort of impulsive, really, going out and trying to contact people from their past. That's certainly something I've seen in patients, and then kind of being a bit embarrassed about how they presented in that moment because, again, they're full of energy. Yeah.
And so that impulsivity can be purchasing. It can be other things as well. It could be booking 12 international trips in one afternoon, or going and buying 3 cars, etc. So impulsivity. The other is grandiosity. People who have manic bipolar disorder, who are in a manic episode, will often display words of or actions of grandiosity. And keep in mind, these are not lies in the sense that the person isn't lying in order to try and pull one over on anybody. These are actual beliefs that the person comes to have about their grandiose position in the world, or grandiose opportunities or potential in the world. Typical forms of grandiosity in manic episodes would be that the person suddenly decides that they are going to win a Pulitzer Prize. They are the person selected to win a Pulitzer Prize. They're going to write a novel that afternoon, and they're going to win a Pulitzer Prize that year, which is more or less a delusion of grandeur, right? The idea that someone could do that in one afternoon, I suppose it is possible in the realm of all possibilities, but it's extremely unlikely.
Professor Huberman, who's writing Pulitzer Prize winning novels in one afternoon? I would respectfully say that's impossible unless you've got skills that I don't even know about. So yeah, absolutely. He's hit on something key. I would go as far as to say that you can't actually define mania unless there's grandiosity. So it's when people think they have these special abilities. And as the professor said, it's not like a lie, it's a delusion. So they believe that they've got these special abilities or power. In cases that I've seen off the top of my head, I've seen people that do pretty rubbish kind of child level style paintings and believe that they're absolutely amazing and worth millions of pounds. I met a man in his 60s who wrote a rap and thought it would top the charts, and it was horrible, man. I have, what else? I've seen people that believe that they've got like business. Oh, that was it. So I saw a man who drew like a design of a rocket, and it was literally like a kid's drawing equivalent and scruffy writing, and he thought it was a special design that was going to make him millions of pounds. And delusions of grandeur. So you can either have grandiose ideas, which are not quite delusional because somebody can kind of convince you or talk you out of it. But in severe mania, you have delusions. So you're absolutely 100% convinced. And so what else have I seen? I've seen people who think that they're related to Jesus Christ, for example. So yeah, exactly this kind of thing.
Other forms of grandiosity that often present themselves in people suffering from a manic episode will be that they're going to run for president, or that they are the person that they believe is selected by the citizens of a given country, or by the universe to be the president of that country or to be president of the universe, right? It sounds ridiculous, but those sorts of delusions of grandiosity are one condition that often presents itself, or one set of symptoms that presents itself.
I reckon I could be president of the universe. What do you think? No? Okay. Yeah, so when he was saying this, it reminded me of Kanye West. Now, it's hard for me to know without assessing him in person whether his intentions of running for president were fully related to his mania. And we know that Kanye West has a diagnosis of bipolar affective disorder, or it could have been a context of him being this rap superstar and having all these yes men around him, which might have fed into his own ego outside of his mania, or it could have been a combination of both of those things. But I think that's a very good example. Yeah. By the way, I've done a video on Kanye West. Go check it out somewhere on my channel. You can search for it. You know how these things work.
Flight of ideas are also typical of manic episodes. So this is a little bit like distractibility, but this would be people talking extensively about one thing and then switching and talking extensively about something else. It would be as if I was doing this podcast talking about manic bipolar disorder and then suddenly switching to OCD and then to deliberate cold exposure and then to the role of sugar and its impact on the brain, et cetera. So essentially a random selection of the different topics that exist in science, all of which I happen to be very interested in and curious about. But just as we have episodes of the podcast that are about one or two topics and we focus on those in a fairly narrow trench of discussion, somebody who has a flight of ideas would be jumping between categories and topics in a kind of pseudo-random way. So they might take off down a path of one thing and then switch to another without any transition, or with transitions that don't have any logical structure to them.
I think Professor Huberman has done an excellent job of describing this. I can't really add anything apart from this. What I think is quite interesting in my experience is that people that have this flight of ideas and keep jumping around, to them it seems logical. So when other people tell them, like the assessing doctor or their family members say that we don't know what you're talking about, you keep changing topics, in their mind, everyone else is too slow to keep up and is not, fast enough or clever enough to keep up with the conversation. They don't think that the way they're speaking is in any way odd.
The other aspect of manic bipolar disorder that often presents itself in the manic episodes are agitation. People feeling extremely physically agitated, so a lot of shaking and moving about. This can venture into the realm of paranoia, but a lot of agitation, a difficulty sitting down and being still, a difficulty in just looking, feeling, and acting calm.
I'm glad he mentioned this because I think it sometimes gets overlooked. So, for example, psychiatry textbooks for medical students, they don't tend to mention the irritability or the paranoia. It's rare. It's not usual. Most people with bipolar feel great. They have an elevated mood and there's no kind of downside or negative cognitions. However, as a forensic psychiatrist, I assess people that have offended, and when they have mania, there is absolutely aggression, irritability. There's even been cases that I've seen of people who have sexually offended because they're so sexually disinhibited, and they're not career offenders, they're not, sex pests when they're lucid and well. It's just when they're in a manic state, their disinhibitions go. Just be really crystal clear, it's only a very, very, very small proportion of people with this disorder. It just happens to be the people that I see in my line of work, but I'm glad he mentioned it because it's the basis of my clinical experience.
Another condition is no sleep. And when I say no sleep, I mean no sleep or very minimal sleep. As incredible as it sounds, people who are in a manic episode can often go 7 days or more with zero sleep. And a key feature of this zero sleep is that they're not troubled by it. They're not thinking, oh, I'm suffering from insomnia and I really, really want to sleep. Sometimes that's the case, but more often than not, they are simply not sleeping. They're staying up 24 hours, then another 24 hours. It just continues for an entire week. Again, inconceivable to those of us that don't suffer from manic episodes. I can only imagine how pulled apart most of us would feel under those conditions. And yet they are just going and going and going with no sleep, up all hours, shopping, talking, running, doing all sorts of different things in the categories of other symptoms that we talked about before. And it doesn't bother them that they're not sleeping. And then the last sort of category of symptoms that the psychiatrist is evaluating for and seeing if they present is rapid pressured speech. The rapid pressured speech is something that when you hear it, you recognize it. This is somebody that almost seems to be hitting you with speech like machine gun fire. It's coming at you, coming at you, coming at you, and there's really no room for conversation. They're not offering any opportunity for a back and forth. Or if there is a back and forth, they might ask you how you feel about something, and then you start, well, I think, and then they're coming to, and then they're going to hit you with another barrage or a paragraph of information or of just speech that's pseudo-random.
Again, the professor has done a really good job of explaining this. It's exactly like that. Obviously, it depends on the severity and the degree of mania, but I've literally done assessments when, for example, I've had to make a decision about whether to section somebody under the Mental Health Act, where I've sat in a room and I've been in there for an hour and I have barely said a sentence because, as the professor says, people with mania have this such pressurized speech. It's like a burst, an explosion of words. They're just talking. They're almost interrupting themselves to get onto the next point. And they very rarely let you speak. And if they do, just like the professor says, they can't help it. They're not being, socially impolite. Their next thought comes so quickly that before you've even got a couple of words out, they're already jumping on top, which makes it quite hard to do an assessment because when I'm a psychiatrist, the symptoms of mania when you get somebody like that are really easy to spot. So making the diagnosis, mania, bipolar, not a problem. But I need to know whether somebody's safe. Because that's one of the key decisions about whether to section them or not. So I need to ask specific questions about, thoughts to harm other people, if they're going out spending lots of money, if they're being sexually promiscuous. So I need to know some key pieces of information, other things that might be relevant, whether they're taking medication, whether they're taking drugs. So the specific piece of information that I need for my assessment. And many times I've been in an assessment and I literally can't get it out. And it's quite frustrating and it's quite challenging because I can't get the question out. And if I do somehow crowbar my question in, they might start to answer it, and before they've even finished their thought, it's not that they're being, intentionally evasive. It's just they can't answer the question because they're so distracted. There's such a pressurized speech, such a flight of ideas. So yeah, that is something that definitely sticks in my mind from assessing people in acute phases of mania.
So we've got distractibility, impulsivity, grandiosity, flight of ideas, agitation, no sleep, and rapid pressured speech. For someone to be diagnosed as in a manic episode, they do not have to be engaging in or displaying all of those symptoms. They do, however, need to present at least 3 of those symptoms, and then in order to meet the condition of bipolar 1, they have to be presenting those 3 symptoms for at least 7 days. It could be longer, but at least 7 days.
Now, respectfully, this is one of the very few areas where I would politely disagree with the professor. It could be different in America, right? I'm just talking about how we do it in the UK. I'm talking about myself and my psychiatry peers. First of all, we use different classification systems, DSM versus ICD, but generally speaking, psychiatrists don't list or number the number of symptoms to come up with a diagnosis. It's more of like a clinical feel or a gut feeling. It's fairly obvious when somebody's in a manic episode. So I guess my point is that in reality, even though it says in the textbooks and it says in the classification systems that you need 3 symptoms for this amount of time, in practice, you don't actually do that. You just go with the presentation of somebody in front of you. The exception is, so I work as an expert witness, so I do assessments and I present evidence for criminal trials. Sometimes in criminal trials, because there's so much riding on this diagnosis, it could be the difference between somebody, having criminal culpability or not, going to hospital or prison or not, getting a prison sentence or not, because it's so kind of important and because it can be contested. So if you're assessing somebody in clinic, it's not contested, you're there to help them. If it's in a court case, you might be working on behalf of the defense, or you might be working on behalf of the criminal prosecution service. You might have to go into court and battle it out with your expert. Because it's being contested, in that kind of scenario, you might have to show you're working like GCSE maths. So you might have to number your symptoms and show the classifications. That's the only context that I've seen it actually where they've counted the number of days and they've listed the number of symptoms. In day-to-day average psychiatric clinics, that just doesn't happen, at least in the UK.
Now, this seems pretty straightforward, right? At one level, the way that I describe this and the way that it exists in the clinical literature, you could think, well, this should be pretty easy to diagnose. And yet there's a complication there or a challenge there because the psychiatrist, again, has to determine that these manic episodes are not due to something other than bipolar disorder. For instance, again, it could be TBI, traumatic brain injury, it could be seizures or meds or other sorts of drugs. Corticosteroids, which are often prescribed for a number of immune conditions or for wound healing, can also cause manic episodes. So they have to determine that everything that's happening meets the criteria I described before, 3 out of 7 of these symptom categories for 7 days or more, and that it can't be better explained by something else going on in that person's life or immediate medical history. That's very important. Now, the other challenge...
What he's saying is technically correct, but in practice, if somebody's presenting to you with the symptoms of mania, what psychiatrists would do, what I would do, is if their level of functioning is an issue and if there's some sort of risk, is I would section them at that point. Or if they've got insight, which if they're this ill, they're not going to have, get them to come in voluntarily into hospital. And then once they've been admitted, then you do the background checks, then you take the blood tests. Because if you don't do it that way and you let them release them back into the community, there's a very good chance they're not going to come to their next appointment. First of all, they don't have the insight, they don't think they're unwell. Secondly, they might not want to come into hospital. Why would you if you think you've got all these great ideas and you have so much to do in so little time because of your mania? And also you've got the resource, so they might not come back to the appointment, whereas once they're sectioned in hospital, you've got the resources to do the blood tests and to look at their medical history. So I guess what I'm saying is in practice, you don't make that decision there and then. As a psychiatrist, you make the decision about whether they need to go into hospital. That is the most important thing at that point. Everything else can be sorted out later.
And this is something that's going to come up again and again today, not just in the description of the biology of bipolar disorder, but also in the description of different treatments and treatment approaches, is that typically when somebody is sitting in front of a psychiatrist, in particular for the first time, those two people are interacting, the psychiatrist is just getting one snapshot of the person at that moment. Right? So the person could be on day 1 of a manic episode. The person might be on day 6 of a manic episode. The person could be transitioning out of a manic episode. Or the person could be suffering from a combination of manic episode where because of the impulsivity of bipolar disorder, they went out and used illicit drugs. They also used cocaine. So the psychiatrist has a serious challenge. The psychiatrist has to determine based on a conversation, right? This isn't a blood test. This isn't a measurement that you can take on a scale or with a biomarker. They have to use language, a conversation with somebody who, by all accounts, is pretty impaired at conversation to determine whether or not they're suffering from a manic episode that is the consequence of bipolar disorder. You can imagine this in the real world as somebody says, well, how long has it been since you slept? And the person starts to answer, oh, well, the other day I went down to the basement. I was going to get something out of the refrigerator and I thought I might take a nap. And then all of a sudden they're talking about something completely different. So they might not even have an answer. So the psychiatrist has to be a really good detective, a benevolent detective, but a detective nonetheless.
I'm glad that you think if that we were detectives, we would be benevolent. Again, with all respect to the guy, and I said this before, I'm a fan of this video, I'm not trying to diss. There's a disconnect, I think, in what he's saying in theory, which is all correct, and what actually happens in practice. So in practice, it's very unusual for you to not have any history on a person that presents with mania. Even if it's the first time that they've presented, and I'll tell you why. It's because usually we have their name and date of birth. So in the accident emergency department in your psychiatric clinic, you can get on a system and look at their old notes so you know that they've got this diagnosis. Of course, there are going to be situations where people present for the very, very first time. It's unusual for somebody to come in without some sort of collateral history, so without a worried family member or a neighbour or whoever's brought them in the first place. Because as I said, it's very rare for somebody to come in themselves. They've usually been brought in by somebody. So there's usually some sort of evidence trail. That's the first thing I'd say. There are exceptions, and there's definitely been some cases in my career, I'm trying to think roughly, maybe, I don't know, once or twice a year, where you've got literally no information on them at all. So either you can't get their name or address, they've been brought in by police, they don't have any available medical records, they live out of area. So I work in London, you get people who are manic who come down on the train from a different part of the country and you can't access their medical records. But it's very, very rare. And I would argue with respect that most psychiatrists, myself included, would err on the side of caution. So what I mean by that is that if you're in that situation, if you're unsure, especially if the person in front of you seems to be a bit disorientated, seems to be manic, seems to not really be making sense, probably lacks insight, can't make sensible decisions, then you always section them. And I'll tell you why. Because think about it as a risk-benefit analysis, right? If you're wrong and it isn't actually mania and you section them, you will find out in hospital within a couple of days, because their symptoms will subside, or they won't be. You'll find out that they're not consistent. If you're wrong and you don't section somebody, I'm not talking about everybody that comes to your door, I'm talking about somebody who looks fairly ill in front of you. If you're wrong, then there are huge risks to their safety, risks to their finances, risks of suicide, risks of them being exploited by somebody. Say if it's a woman who's disinhibited, being exploited sexually, risk of them getting into a fight because they're acting inappropriately. So I would argue that it's safer and it's the more humane thing to do to get somebody into hospital first and then rule out mania later than the other way around, then on balance saying no, they're probably all right, sending them into the wilderness where anything can happen to them. I have used the word section as opposed to voluntary hospital admission. Of course, somebody who wants to come in and has the insight can come in voluntarily, so you don't have to section people. But in mania especially, compared to a lot of other psychiatric disorders, compared to, I don't know, OCD, depression, eating disorders, in mania they don't have insight, especially at the beginning of their illness. So it's more likely than not that they will need to be sectioned.
In determining whether or not these symptoms have existed for 7 days or more and whether or not they meet at least 3, it could be more, but at least 3 of the criteria of symptom categories I talked about before. Now, assuming that they do, assuming that the patient meets those criteria, they are likely to be diagnosed with bipolar 1. Now, bipolar 1 disorder means they're having these extended manic episodes, 7 days or more, but it does not necessarily mean that they are dropping into a depressive episode as well. This is a common misconception about bipolar disorder because, as it's often called, bipolar disorder is referred to as bipolar depression, and yet many people with bipolar disorder don't necessarily experience the deep depressive episodes. Many of them do, but many of them do not. So somebody can truly be diagnosed accurately with bipolar 1, even though they're only experiencing manic episodes and then dropping down to baseline. Manic episode, then dropping down to baseline. That's very important to understand.
Okay, kids, I think I'm going to stop there because this video is getting too long. If you're interested in this and you want me to carry on analysing Professor Huberman's video, including him talking about bipolar 2, then let me know in the section below and I'll do that. Just a couple of closing comments on what he just said. I would say that some psychiatrists believe there's no such thing as bipolar 1. So what I mean by that is some psychiatrists think that everybody who's been manic at some point will, at some point in the future, get a depressive episode. Now, it might be a few months, it might be years, it might be 5 years, it might be 10 years down the line. But some psychiatrists, including people I've worked with, think that there's no such thing as only mania. I have not worked long enough to make a decision on that yet. I assume that there are people that don't have depressive episodes, which is bipolar 1, versus people that have depressive episodes, which is bipolar 2. I've definitely seen a lot more bipolar 2 than I have bipolar 1. So yeah, my personal jury is still out on that. Okay, I'm going to end here. Just in conclusion, I think this is an excellently made video. I'm not dissing it. I just think there's a few things that are right in theory, but actually work slightly differently in practice when you've got somebody there in front of you as a psychiatrist that you need to assess. I like this dude's style, very informative, really well made. Everything that he says, well, most of what he says, I agree with. My only criticism is that you don't need 2 air fryers unless you've got ridiculously big chicken nuggets. If you're interested in this kind of video, go check out the rest of my channel. I've done a few reaction videos, sometimes on like high profile trending things like Amber Heard, etc., etc. You know how to search my videos, I don't have to tell you. Okay, I'm gonna go now. I just wanna say, buy my goddamn book, stay euthymic, and the most important thing, do not forget, I love you.